Welcome to the Los Robles Health System 26th Annual Breast Cancer Symposium. My name is Dr. David Chi. I'm a surgical oncologist and a chair of the Cancer Committee at Los Robles Hospital, and I'm once again honored to be part of this important event. Since 1996, Los Robles has provided this forum every October in recognition of Breast Cancer Awareness Month, and for more than a quarter of a century, our commitment to our community has remained steadfast. First, I'd like to thank all of you who are joining us today to learn more about breast cancer. As many of you know, breast cancer is the most common cancer that is diagnosed in women in the United States. In fact, it's more than twice that of lung cancer and 4 times that of colon cancer. 1 out of every 8 women will be diagnosed with breast cancer at some point during her life. So breast cancer transcends gender, race, age, socioeconomic status. It touches us all. Secondly, I'd like to thank Pepperdine University for allowing us to showcase their incredible campus. Pepperdine is globally recognized for its contributions academically and socially, and we're excited to be partnering with Pepperdine to bring you this year's symposium. One can't overstate the disruption that the COVID pandemic has had on each of us, personally, socially, financially, and medically, the degree of which we've never witnessed before in our own generation. The first case of COVID within the United States actually occurred in the state of Washington on January 20th. And by March 4th, California was in a state of emergency. At Los Robles, we actually had our first case of a positive COVID test on March 18th. And by the next day, California was issued a shelter-in-place order in an effort to help flatten the curve. Because of this, the surge in hospitalizations, we quickly began experiencing a shortage in hospital beds, ICUs, ventilators, PPEs, and other resources. And because of this, shortly after that, we had a hold on elective surgeries and screening mammograms. By April 20th, 5 leading organizations in cancer care jointly published guidelines for the management of women with breast cancer during the pandemic. And while the hold on elective surgeries and screening mammograms was lifted by June 16th of 2020, many people were still wary of the pandemic and continue to forego their screening mammogram. The effects of the pandemic were obvious, and many studies demonstrated the impact in screening mammograms. In one study, there was found to be an 87% drop in mammograms in April of 2020, with an 84% drop in screening for cervical cancer during that time period. The impact of the breast cancer was demonstrated in a paper that was published in January of 2022, early of this year, by the Kaiser Permanente group. And in this study, they actually looked at the data between 2019 and 2020. And compared to the pre-pandemic era, during the COVID pandemic, fewer breast cancers were diagnosed. And of the breast cancers that were diagnosed, 78% of them were symptomatic, compared to 37%, which were from the year before. The breast cancers that did present were of a higher grade, and while the stage 4 disease was unchanged, more women underwent mastectomies as opposed to lumpectomies, and the time from the diagnosis to treatment was longer. In light of these observations, the director of the National Cancer Institute, Dr. Norman Sharpless, published a paper in the journal Science in June of 2020, where using simulation modeling, he calculated that due to the delay in screening, by the year 2030, over a 10-year period, there will be an excess of 10,000 deaths from colon cancer and breast cancer. These startling revelations led to other simulation model studies. In this paper from the Journal of National Cancer Institute in 2021, this study, they examined models in which the patients during the pandemic for the first 6 months would have a reduced number of screening, delays in symptomatic cancer diagnosis, and reduced use of chemotherapy, with return to levels after 6 months. In this study, they found that by the year 2030, there would be more than 950 excess deaths due to reduced screening, over 1,300 deaths from delayed diagnosis of symptomatic cases, and over 150 deaths from reduced use of chemotherapy. And if the duration of these delays extended for 12 months, from 6 months to 12 months, actually the number of breast cancer deaths doubled. So the authors concluded that small disruptions in diagnostic imaging resulted in a large number of deaths. However, rapid resumption of screening mammography would actually result in saving thousands of lives. This information, however, is not anything that actually new. We've known about this for 40 or 50 years. In the early 80s, multiple organizations such as the American Cancer Society launched campaigns which emphasized the importance of screening mammograms and tried to raise public awareness about the importance of getting the screening mammograms. And through the efforts through the 80s, by 1990, for the first time ever, we actually began to witness a drop in the deaths from breast cancer. And while this exciting news is probably attributed to multiple factors, most experts agree that screening mammograms played a major role. So because of this, the effects of the pandemic on breast cancer screening, many organizations began emphasizing efforts to try to increase the awareness for the importance of screening. The American Cancer Society this year is doing their Get Screened campaign, which aims to increase public awareness regarding the importance of screening and get people back on track. The American College of Surgeons and the sub-organizations, the Commission on Cancer and the National Accreditation Program for Breast Centers, started their Plan, Do, Study, Act Quality Improvement Project initiative, where they examined the impact of physicians trying to emphasize the importance of cancer screening for their patients. The problem, however, is that the guidelines for screening mammograms results in a lot of confusion, and the main reason for that is that there's a lack of consensus from various organizations as far as what to do regarding screening mammograms. Organizations such as the American College of Radiology, the American Cancer Society, American Society of Breast Surgeons, American Medical Association, American College of Obstetrics and Gynecology, National Comprehensive Cancer Network, and the United States Preventive Services Task Force, they all come out with their own guidelines, and based upon things such as age and interval of time between screening, when to stop screening, even the whole idea of whether even to screen at all is hotly debated. And because of the variability in recommendations, this results in a lot of confusion that we as healthcare providers have to deal with on a daily basis. The other problem too is you need to keep in the context that these recommendations apply for individuals who are considered to be at average risk and are asymptomatic. People who are considered elevated risk, they may need to consider modifications, and those individuals include those who have hereditary breast cancer syndromes, such as the BRCA1 and BRCA2, people who have strong family histories of breast cancer, women who have dense breast tissue on their mammograms, prior history of chest radiation, and we're not talking about diagnostic imaging, we're talking about therapeutic radiation for treatment purposes. A personal prior history of breast cancer, women who've had biopsies demonstrating at-risk situations such as atypical ductal hyperplasia or atypical lobular hyperplasia or lobular carcinoma in situ, or people who have been found to have higher risk based upon risk models, and the best known are the Gale model and the Tyler-Cuzick model. In those individuals that are considered to be at elevated risk for breast cancer, modifications should be considered, and modalities such as more advanced imaging, such as tomosynthesis, which is also known as 3D mammograms, supplemental imaging, including ultrasounds and breast MRIs, increased frequency of screening, genetic counseling, and even some risk reduction strategies, including medical, such as the use of drugs like tamoxifen, or surgical, such as prophylactic mastectomies. But the most important thing to realize is that these are generalized recommendations, and for each individual, the screening regimen needs to be determined based upon the person's goals, the risks, and the individual situation. For me, in my practice, for my average risk asymptomatic patients, I typically recommend starting mammograms age 40, and they continue with the mammograms in conjunction with a clinical breast exam every year for as long as it's felt that their life expectancy is at least 5 to 10 years. Once again, thank you for joining us for this year's Breast Cancer Symposium. We really appreciate your willing to learn more about this important disease, and please remember it's important for this getting back to screening. We'd really like to again thank the Pepperdine for partnering with us to bring you this year's Breast Cancer Symposium, and we look forward to seeing you for next year's event. Please check back on regularly to get more updates as far as the program for next year, and we look forward again to seeing you then. Wishing you all the best of health and happiness. Thank you.